Okay everyone, and welcome to your first presentation for the clinical infection strand of year 3 of the MPharm course. And this is a quick presentation just to introduce you to the concept of what is an infection, what sort of people are more likely to get infections, what can cause infections, and basically how we treat infections. So it's just covering all the major principles. The idea is that you'll listen to this before your first workshop on Thursday the 5th of December. Okay, so what is an infection? Well, infection is an invasion by and multiplication of pathogenic microorganisms in a bodily part or tissue, which may produce subsequent tissue injury and progress to avert disease through a variety of cellular or toxic mechanisms. Very long and wordy description, but it's also a very good one. I think the key thing to remember is this word here, pathogenic. Okay, the body constantly has, millions of microorganisms that live either symbiotically with the body, which means there's a benefit to both us and the microorganism, or commensally with the body, which means that we do no harm to each other. So for instance, the lower gastrointestinal tract, the intestines, if we didn't have any nitrogen fixing bacteria there, we'd actually have diarrhea all the time. So that's an example of commensal flora, and there's many on the skin, on the inside of the respiratory tract, on the inside of the gastrointestinal tract. And basically, we're always in a state of an uneasy truce between us and the microorganisms, or the flora, whatever you would like to call them. And an infection is where that truce gets broken and it becomes a war between the pair of us. And that can happen if bacteria get to the wrong part in the body, and I'll talk more about that in a little while. So really, what do you need for an infection? Well, I'm sure you're quite aware. The first thing you need is an organism, and the second thing you need is a host. And obviously we're going to concentrate on us human beings as the host. And that tends to cause an infection. Okay, so the easiest example of an organism is, for instance, one of the major commensal organisms of the body is streptococci bacteria, and they live quite happily on the skin. However, if you get a bit of a cut in your skin, the streptococci can invade that cut because they're already there in the same location, especially if you don't try and prevent the infection and don't wash the wound properly. What that can lead to is something like cellulitis or an ulcer, or in a worst case scenario it can be the flesh-eating bug, necrotizing fasciitis, which is caused by Streptococcus pyogenes. So basically an organism in the wrong place that starts to replicate, that causes an infection. But obviously the body's aware that these things can happen in the design of it, and there's quite a few mechanisms to stop us from becoming infected. So for instance, the organisms that can cause infection tend to be viruses, fungi, bacteria, protozoa, can also be prions in some cases, which cause mad cow disease or variant Creutzfeldt-Jakob disease. So you have a few natural defences against infection. The main one of these is skin. Okay, that's the physical barrier. Lysozymes are often contained in tears, because the eyes don't react well to infection, so they tend to be an extremely clean environment in the body. pH, okay, so for example the stomach has a pH of 2, and that destroys most bacteria before they can actually colonise the lower gastrointestinal tract, the intestines, etc. Phagocytosis, or basically where white cells eat bacteria, that is, or ingest them, for want of a better word. That tends to be undertaken by neutrophils, which are a specialised type of white cell. And then complement and plasma proteins tend to attract white cells to an environment where an infection is taken place. If you want a really good summary of the immune response to an infection and inflammation, then there's a video on the Khan Academy which I will signpost you to on the KLE, which talks about this in much more detail at a microscopic level. Okay. Another thing to remember is an infection doesn't always cause disease, and probably the best example I can think of this is TB, where it's approximately 1 in 6 people in the world actually has a latent TB infection, And that's not a disease state, they're not particularly coughing, they don't particularly have a high temperature. But what's happened is they've become colonised by the Mycobacterium tuberculosis. And that's living in a part of the body. It normally lives in things called granulocytes or granules that can be often x-rayed on the lungs. They're not infectious to other people, they're not physically unwell, but they are at higher risk of developing infection. So an infection doesn't always cause a clinical disease in a patient. Okay, so infections have been with us for thousands of years, and the first person that tried to quantify what an infection was this chap, Aulus Cornelius Celsus, a Roman that lived about 2,000 years ago. And he came up with these 4 things that he saw in every infection. So for those of you who don't have a knowledge of Latin, rubor is from where we get the word for redness. Calor, like calor gas, is for heat. Dolor from dolores is for pain. And tumor, if you think what a tumour actually is, it's a swelling or a growth in part of the body. So those 4 things are often associated with infections. However, they're also associated with inflammation, so it's not that clear. For instance, often infections are termed in what is actually inflamed by the infection. Okay, so an appendicitis would be actually only an inflammation of the appendix, which is most often caused by an infection. Okay, so if we have a look at this one, it's got all 4 classical signs, but the key thing is this little white stuff here, which is pus, which is a local sign of infection. Okay, so you've got the rubor, the calor, the dolor, the tumour there in that picture. Okay, the little abscess. Whereas this one here, you've definitely got heat, you've got swelling, you've got redness in this section here. It's probably quite painful as well. However, that would actually just be a joint injury. So this chap may have broken his toe. Okay, has all the 4 classical signs. So we have to look a bit closer into what actually clinical signs there are of an infection. Okay, so inflammation can be caused by any one of a number of things. Okay, whereas infection is always caused by one of these 4 things, or also something known as a prion, which is a small bit of protein which can cause diseases such as scrapie or variant Creutzfeldt-Jakob disease, mad cow disease for want of a better word. However, there are blurred lines between the 2 different things. So for instance, infection actually causes inflammation, okay, whereas a physical injury, burns, frostbite, actually increase the risk of infection. So foreign bodies in the body will increase the susceptibility of a patient to infection. Okay, so what are the signs of infection? Well, there are a few. You can look at local signs and systemic signs. So if you're looking at systemic signs, what happens is basically the body reacts to an infection and tries to fight it off. And these are natural responses. So it raises the core temperature, so you get fever, can increase the heart rate to drive blood around the body more. It increases the amount of white blood cells that it produces. It also increases these CRP and ESR, which are known as acute phase reactants, and they're also increased in inflammation as well. Okay, so they're not specific to an infection, but you may see them raised in an infection. Okay, so more local signs, you may get purulent sputum production with a respiratory infection. Okay, you may get local erythema in the presence of pus with skin infections. Okay, you may get dysuria, painful urination, when you have a urinary tract infection. Okay, so signs and symptoms lead us to where the infection actually is in the body. Okay, and we can also divide them up into what are known as clinical signs, so they're things you can actually see wrong with your patient, and biochemical signs, which are where we're actually looking either under a microscope or we're doing biochemical tests. So again, fever, aches, pain, pus, swelling, redness are the more local ones. Okay, can see changes in blood pressure, heart rate, respiratory rate, chest x-ray. These tend to be more severe infections where you see them. Okay, Also see confusion in elderly patients, and then drowsiness, irritability, or poor appetite in children. And infection can reduce, especially in elderly patients, renal function. Again, this would be a more severe infection. Okay. Biochemical results, you see an increase in each of these. So neutrophils are a specific type of white cell that phagocytose microbes, bacteria, viruses. You can also see increases in the acute phase reactants. Okay, and they give you your typical symptoms of man flu, okay, where you have somebody in bed, they're particularly unwell, they feel like they're dying, very high temperature, don't want to move, very achy, okay, very drowsy, and that's a body's natural reaction to an infection. Okay, so how do we treat an infection? Well, you've got to say there's one basic rule, and prevention is better than cure. Okay, we've only had, for the last 150 years ago, anything that can particularly target a specific disease state. Before then, we just had good hygiene measures, and only in the last, 70 years or so, since the 1930s, that we actually have treatments for infection. Okay, so what did the readers of the BMJ vote for the greatest medical advancement? They actually voted for sanitation. Okay, because that prevents one of the major modes of transmission of an infection. So one key rule to get into your head is preventing infections is always better than... Okay, so prevention campaigns aim to reduce the transmission of bacteria, and we do that by basically preventing them from being transmitted from one host to another. Okay, and there's a few ways bacteria or any infections can be transmitted, and there's direct routes, which include fecal-oral, which is basically where people don't wipe the bottom or wash their hands after they've been to the toilet and then go and touch other people and then they wipe their mouths. Kissing, droplet spread, okay, or sexual contact are the more direct routes. Whereas the indirect routes involve a vehicle, such as food or water, that may carry the pathogen. A vector, okay, so the most common vector-borne disease that we have is malaria, okay, and that's a vector for the parasite, so without the mosquito, the parasite wouldn't affect humans, or it can be airborne transmission, which is one of the most difficult to prevent. Okay, so if we look at two recent prevention campaigns in the UK, the NHS Wash Your Hands is to prevent fecal-oral and direct routes, whereas the Stopping Sneezing Spreads Diseases, okay, is more for droplet airborne spread of disease itself, so the more indirect routes. We can also use things like vector control measures, so trying to use insecticide on malaria mosquito populations would be an example of that. Okay, the most useful form of prevention we have are actually vaccinations. Okay, they've been around for about 150 years, and people forget that vaccines are actually drugs. And they're really brilliant drugs because you only need 1, 2, maybe 3 injections, and then you're immunised against the disease for 10 years, as opposed to a tablet of atenolol that you have to take for the rest of your life, and it may prevent you having a heart attack or just slightly reduce your risk. These, are 80-90% effective against stopping diseases such as pertussis, such as diphtheria, which were big killers, before the 1930s and mass vaccination programs in the UK. One thing vaccines can also do is this concept known as herd immunity, okay, and that's basically where if you vaccinate more than 90% of a population in a given place, the other 10% won't get the disease as well. And that's where you see, recent scares about measles, is where actual vaccination levels have dropped below the 90% in these areas. Okay, so vaccines are really good, and we really like them. And as a pharmacist, you should really promote vaccination schedule, because there's a lot of evidence out there to say that they're extremely effective. Okay, but what about if you actually get the infection? How do you treat it? So you need to know something about the bug, something about the patient. And if we concentrate on bacterial infections, what do we know about bacteria? Well, we can probably group them into one of 3 major groups. We can group them into gram-positives, gram-negative cell walls, okay, and then we can group them into anaerobes as well. Okay, and dependent on the type of bacteria that's likely to cause your infection, you choose an antibiotic that's going to be safe for the patient. Okay, so for instance, if you've got an elderly patient, okay, you have to take far more into consideration the fact that they may be more susceptible to infection, they may have comorbidities that may affect their drug handling, so they may have kidney failure, whereas a younger patient is much more likely to tolerate an antibiotic, but then again at the same time they're much more likely to fight off their infection with their immune system. Okay, so the actual state of someone's immune system is something that you need to know about the patient. Okay, so if we look at it on a really basic way, if you have an infectious disease, you give them an anti-infective agent. Okay, bear in mind you want to choose an anti-infective agent that will treat the disease. Bear in mind you don't want too many side effects with that, and hopefully that should resolve the infection. Okay, but we have to monitor patients afterwards. Okay, so if we concentrate on bacteria, again, are they friend or foe? Bacteria are not always pathogenic, and often they're commensal in the body. So I mentioned before, a lot of staphylococci, streptococci live on the skin. A lot of anaerobic bacteria live in the large intestine. However, where the infection is often gives us a clue to the type of bacteria that will infect. So bacteria have preferences for where they infect the body. And what I'm going to do is just give you a few ideas about how we treat this and how we often guess how to treat a patient. Okay, we don't call it guesswork, we call it empirical therapy. So basically, looking at where an infection is in a patient, looking at their immunity status. Okay, so if a patient is immunocompromised, has a weak immune system, there's a lot more variations of permutations of bacteria that could infect a patient. Okay, so in an ideal world, what we'd do for every patient that has an infection, we'd take a culture of what's infecting, so the infective part, so that may be a sputum sample in a respiratory infection, a midstream urine sample in the case of a UTI, and then we do sensitivities with lots of different antibiotics, and we find an antibiotic that treats them. The problem is that takes time, okay? And often time isn't something we have in an infection. In the case of a life-threatening infection, patients can die within 24 hours. Okay, we need to actually treat them a little more quickly. So what we do is we guess at the most likely pathogens. We look at local policies and guidelines, local resistance patterns. So for instance, if someone gets an infection in a hospital up in Glasgow, it's likely to be a slightly different strain from a hospital in London. And then we look at the ability of an antibacterial to reach the site of action. So for instance, if someone's got an infection in the bones, there's antibiotics such as fusidic acid, which are much more likely to congregate in the bones. Again, if it's in a UTI, it's in the bladder, nitrofurantoin is much more likely to concentrate in the bladder than, say, fusidic acid. So we need to know things about the antibiotic, the patient, and the bacteria. In some cases, we may want to use combination therapy. So you may see that in the case of Helicobacter pylori infections, you may see it in the case of TB. And basically the idea is we're looking for either synergistic activity or to prevent the spread of resistance in bacteria. Okay, so what I have here is a little man, and I'm just going to write some of the common infective agents on his organs here. So for instance, in the lungs, one of the most common infective agents would be Streptococcus pneumoniae. In the bladder, you would get Escherichia coli. In the large intestine, one of the most problematic organisms is Clostridium difficile. And then on the skin, you tend to get Streptococcus pyogenes or Staphylococci that cause problems on the skin. So what we have to do is generally, in empirical therapy, you use an antibiotic which will actually treat the bacteria that's most likely to be causing the infection. So for instance, in strep pneumoniae, there's a few others like Moxarella catarrhalis and Haemophilus influenzae that tend to cause pneumonias. The really good choice is amoxicillin. So it's quite broad spectrum against those agents. Okay, for UTIs, E. coli, trimethoprim or cephalosporins are often very useful. Okay, skin infections, strep pyogenes, staphylococci, you often use a narrow spectrum agent such as flucloxacillin. We'll normally treat both of those. Okay, and then the nasty one is Clostridium difficile. The overgrowth is often caused by the use of other broad spectrum antibiotics such as amoxicillin or coamoxiclav, which is a combination of amoxicillin and clavulanic acid. Okay, so how do you treat Clostridium difficile? Well, it's an anaerobic bacteria, so you use metronidazole, okay, which is the drug of choice for treating any anaerobic infections. So you may often see it used for mouth infections because your mouth is most often colonised by anaerobic bacteria as well. Okay, so that's a brief guide to empirical therapy. We'll do more about it in the workshops. Okay, so when antibiotic treatment goes wrong, you tend to get two kind of problems. Resistance and often life-threatening side effects. So we're just going to go in. So in resistance cases, you can get things like MRSA, alright, which stands for methicillin-resistant Staphylococcus aureus, real problem in hospitals. You can also get things like multi-drug resistant TB, okay, and then you can get strains of bacteria. So for instance, one hospital I worked in used a great deal of ciprofloxacin amongst its elderly patients, and they managed to infect all their patients with a ciprofloxacin resistant form of Clostridium difficile. Okay, life-threatening side effects. Okay, so let's think about gentamicin. Okay, that can actually give patients renal failure. Okay, so the benefits of treatment always have to outweigh the risks. Okay, another one, clindamycin. Okay, you'll see this in the BNF. Causes something called pseudomembranous colitis. Okay, which is often down to a Clostridium difficile infection. Okay. What clindamycin tends to do, really useful antibiotic for skin infections such as cellulitis, but it also wipes out the normal flora of the lower gastrointestinal tract and allows Clostridium difficile to multiply, causes an inflammation in the colon which can cause a condition called toxic megacolon, where the colon swells well beyond its normal size and can poison a patient very quickly. So we want to avoid those when antibiotic treatment goes wrong. So in summary, about an infection, we always want to prevent an infection before curing it. Antibiotics are not always the answer, especially in young fit patients. Often they can actually shake off infections themselves. We need to know what sort of bug's likely to be causing the infection. And about the patient, we want to know whether they're elderly, whether they're young, whether they're immunocompromised, okay, because that gives us more as a clue as to what the bug may be. And one thing we haven't mentioned is basically the duration of treatment and the route of administration depend on the severity of infection. So for instance, we'd use intravenous, okay, in life-threatening situations, okay, or if someone's in hospital, okay, where we want a quick resolution of the problem. Whereas oral will work for most basic situations. We'll go into all of this in more detail in the workshops that you have lined up for you. Okay, thank you very much for listening.